And now we return again to the brachial plexus. As you may note, much of this will be a repeat of what we discussed on the prior page, and serves primarily to hammer in these relatively distinct clinical entities. The circled numbers correspond to the injury in the legend on the left. Number 1 is a waiter's tip, which is an injury of the upper trunk as we discussed before. Number 2 is a total claw or Klumpke's palsy, caused by an injury to the lower trunk. Number 3 is one we haven't discussed before, which is a wrist drop. This occurs with an injury to the posterior cord, though notably there are other injuries that could cause this presentation. Namely, the 6th labral nerve, or radial nerve injury, could cause wrist drop as well. This makes sense, as the posterior cord itself gives off the radial nerve. The 4th nerve injury is a very important one to remember. That's a long thoracic nerve injury. This causes a winged or prominent scapula. We'll discuss this in greater detail in a moment. The 5th labral nerve is the axillary nerve. The main muscle that the axillary nerve innervates is the deltoid, and accordingly, axillary nerve injury leads to deltoid paralysis. The nerve labeled 7 is the musculocutaneous nerve. We haven't discussed this nerve before, but it is the nerve that innervates the flexors of the elbow, namely the biceps brachii. But since it's the musculocutaneous nerve, it also is responsible for some cutaneous innervation. Injury to the musculocutaneous nerve, therefore, is pretty intuitive, as it causes difficulty flexing the elbow and variable sensory loss depending on the site of the lesion. The next lesion is the distal median nerve injury we discussed before, with decreased thumb motion. This is referred to as an ape hand. Remember, a more proximal median nerve injury, say around the elbow, would produce the deficit called the Pope's blessing. The final injury is one to the distal ulnar nerve, which causes difficulty with the intrinsic muscles of the hand. This causes what's referred to as an ulnar claw hand. Again, that was another whirlwind of information. When you think about how many nerves there are on the brachial plexus, and the fact that people do some crazy things and wind up injuring themselves, it's a wonder that the plexus isn't injured more often. One thing that helps is that the clavicle presents many direct injuries, and as an added layer of protection, the subclavius muscle also protects the brachial plexus, which is necessary as people often fracture their clavicle. One thing that helps is that the clavicle presents many direct injuries. As an added layer of protection, the subclavius muscle also protects the brachial plexus, which is necessary as people often fracture their clavicle. This table is another permutation of similar information we've mostly already discussed. To this point, we've discussed the different nerves, the different areas of injuries, both distal and proximal, and mechanisms of injuries. Prior to this, we've only grazed over the motor and sensory losses associated with each injury, though. This table really goes into more depth. We'll skip over reviewing things we've already discussed and focus primarily on motor and sensory deficits associated with each nerve. In some cases, though, we've basically discussed all of it, i.e. the musculocutaneous nerve. Also, before we begin, one quick note. The sensory deficits in the rightmost column may appear a bit random. That is, you'd think the sum of the 5 nerves-associated sensory deficits should give you a rough picture of sensation across the entire arm. This doesn't actually play out because many of these 5 nerves actually overlap, so sensory deficits only really occur if a nerve has a region that primarily innervates by itself. As you'll see, this doesn't happen all that often until you get to the hand. For the axillary nerve, this is straightforward, and we've already discussed most of it. The motor deficit is at the deltoid, which means the presentation will likely be difficult abducting the arm. The associated sensory deficit is the skin overlying the deltoid. The radial nerve is more complicated, as you likely have already realized. There are 4 muscles, or muscle groups, to associate with the radial nerve, and most of them are extensors, giving rise to its nickname, the great extensor nerve. You can remember them with the memory aid BEST: brachioradialis, extensors of wrist and fingers, supinators, and triceps. The associated sensory deficit follows the course of the radial nerve. Posterior arm, into dorsal hand, and ultimately dorsal thumb. Next, we'll look at the median and the ulnar nerves. The median and ulnar nerves each have motor and sensory deficits broken down by either proximal or distal lesions, following the pattern we discussed before. We'll start with the median nerve. Proximal median nerve injuries will cause difficulty with flexion of the wrist and the lateral fingers. Accordingly, loss of median nerve innervation will lead to loss of sensation of the lateral 3½ fingers on both sides of the hand, as well as the thenar eminence. More distal lesions will have a fairly different presentation. They usually occur at the median nerve at or more distal to the wrist, and present with difficulty opposing the thumb. The sensory loss is identical, except that you keep sensation to the thenar eminence. Proximal ulnar lesions also lead to difficulty with wrist flexion, as we saw with the median nerve, but this time it leads to medial finger flexion difficulty. The sensory loss of proximal ulnar lesions also has some similar correlates. It occurs on the medial 1½ fingers and the hypothenar eminence. Distal ulnar lesions are actually quite different. First, there is no sensory loss, and the motor losses are quite varied. There is loss of abduction and adduction of the fingers, loss of adduction of the thumb, and loss of extension of the 4th and 5th fingers. As I said, we've discussed most of the important aspects of the musculocutaneous nerve already, but as a brief review, injury causes difficulty flexing the elbow and causes sensory deficits in the lateral forearm. Before we move on to some of the named clinical entities that we've referenced but haven't defined, we want to call out one more important piece of this table. That is the nerve roots that are indicated next to each of the named nerves in the first column. While it's not the most high-yield information to remember, it may be worthwhile as you create a system for remembering the entire brachial plexus. And now the long-awaited waiter's tip. Now that we've talked about this topic a few times, let's actually learn how these patients present. As a review, this occurs with upper trunk injury and follows a direct trauma or a trauma during delivery through the birth canal. Clinically, patients present as this picture here indicates. The patient has their limb hanging by their side, medially rotated with a pronated forearm. This occurs because of the loss of some of the abductors, namely the C5 and C6 roots, which contribute to the axillary nerve, as well as the loss of the lateral rotators and biceps, which derive innervation from the C5 and C6 roots via the musculocutaneous nerve. As we discussed before, thoracic outlet syndrome occurs as a result of an additional cervical rib that pushes against the C8-T1 nerve roots. It may also affect the subclavian artery. The constellation of symptoms that you see all derive from the compression of these two structures. First, as with all chronic denervation, the distal muscle groups innervated by this trunk lose their endogenous trophic factors and undergo atrophy. This includes the thenar and hypothenar eminences, as well as the interosseous muscles. As the C8 and T1 dermatomes are on the medial side of the arm, this compression also leads to sensory deficits of the medial forearm and hand. Finally, and likely the most interesting of all these clinical features, is that the radial pulse disappears when the patient moves his or her head toward the ipsilateral side as the cervical rib compresses the subclavian artery. This syndrome can also result in damage to the lower trunk of the brachial plexus, leading to Klumpke's total claw, which we'll discuss momentarily. We have at some point discussed all four of these hands. However, now we'll discuss exactly why they present the way they do. In almost every case, it relates to the lumbricals. These peculiar muscles are responsible for doing three things: flexing the MCP joint, extending the DIP and PIP joints, and confusing medical students for decades. The first distortion is called the ulnar claw, and it's fairly straightforward. Loss of the ulnar nerve distally leads to a loss of function in the medial lumbricals, which causes an inability to extend the fingers. When the patient tries to flatten or open their hand, their pinky and ring fingers stay clawed. This creates the well-known Pope's blessing hand. Another clinical entity can look quite similar, but is actually a median nerve injury. Here, a patient may lose the ability to flex the lateral fingers, so if they tried to flex these fingers, they would appear to have a similar Pope's blessing appearance. The next claw is the median claw. Here, a distal median nerve lesion occurs, leading to a loss of the lateral lumbricals. This is in opposition to an ulnar claw, which affects the medial lumbricals. Hence, if a patient tries to open their hand, their first two fingers stay clawed, and you see a median claw hand. The third distortion of the hand is the ape hand, wherein a patient suffers from a proximal median nerve lesion. This predominantly affects one nerve and ultimately only one muscle, the opponens pollicis. The opponens pollicis is responsible for opposing the pollex or the thumb. This leads to an unopposable thumb, much like an ape, thereby making it an ape hand. The final distortion of the hand is the Klumpke's total claw, which we discussed in the context of lower trunk injuries, as well as thoracic outlet syndrome. Here, there is a lesion of the entire lower trunk, causing patients to lose function of all of their lumbricals. If you imagine lumbricals being responsible for MCP flexion and DIP-PIP extension, then loss of these means that the muscles that do the opposite action are all unopposed. Therefore, the presentation for these patients is a hand with MCP extended and DIP-PIP flexed for a total claw hand. The next fact is mostly an extension of the information you learned a few pages back. Remember when you sever the long thoracic nerve, the resulting injury is a winged scapula. This is because the serratus anterior is the muscle that is innervated by the long thoracic nerve. The function of this muscle is to oppose the scapula to the posterior thoracic wall. Without it, the scapula protrudes posteriorly, much like a wing would. The classic question that you'll see on your boards is a patient who has a surgery for breast cancer, often with an axillary dissection for lymph nodes, who then presents with a winged scapula after the surgery, with or without lymphedema. This is because the dissection process, or even the mastectomy itself, can sever the long thoracic nerve. The next section is here to highlight some important muscles in the hand. Why? Because the hand is complicated. While it's not incredibly likely you'll see something about this on your boards, it's worth remembering what the muscles are because the case vignette will likely offer the motion of the hand that is compromised. If you understand the anatomy, you should have most answers easily available to you. There are four sets of muscles that you should remember. The first is the muscles you'd find in the thenar eminence. There are ones that oppose, abduct, and flex the thumb. Specifically, you have the opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. There are similar muscles accordingly found in the hypothenar eminence for the little finger. The third set of muscles are the interosseous muscles, both the dorsal and palmar set. The dorsal interosseous muscles abduct the fingers, while the palmar interosseous muscles adduct the fingers. The memory aid, dab and pad, is a great way to keep these two straight. The final set of muscle is the lumbricals. The action of these muscles is a bit strange, as we've already discussed. They not only flex the MCP, but also extend the DIP and PIP joints. Does anyone remember what hand distortion results from the loss of function of all the lumbricals? That's right, a clumky's total claw, often caused by a lesion of the lower trunk.